Дякуємо, що згодилися на те, що продовжуємо.
Thank you very much, dear ladies and gentlemen, for staying with us to proceed with our discussion. So we will launch our next discussion. So this is the acute stage of TBI management. This is the name of our panel. And so we will talk with the people who do this, namely, let's say, on site. So, and let me, first of all, to introduce you the moderator. This is the instructor of technical medicine, Maria Nazarova. Your applauses, ladies and gentlemen. I hope you hear me. So now it will be the presentations of the slide. So we will go through all the stages. First of all, from the let's say on-site medical staff who don't know much about TBI, up to the multidisciplinary team. So again, I will not speak about the details of TBI, so I mean management and treatment, but mainly I will focus on return to duty of our service members. So the majority of patients that we accept, these are the patients with MTBI. That's why I would like the resolution of our forum to develop the recommendations to be introduced in the summary documents of our event. So where we talk about TBIs. First of all, we talk about the mechanism of trauma and everything that includes the TBI, that first of all is reported to the open TBI, like those who have seen open TBI. Raise your hands. Okay, so but what to do with the patients with MTBI who just have the nausea and vomiting? So let's go on ABC. That first A, the A stage. So we say do not install any drainage in case the patient has the liquor or CF and so leaking through the nose. So TC3 is built the way like we are training persons in the, I mean, our professionals into the most severe symptoms. But so we teach them to differentiate the shock and pneumothorax. And so we also tell them to inject 2 grams of tranexam acids. So we do it in everyone who is in the condition of shock. And so all the patients with concussion also should receive 2 grams of tranexamic acid. But again, if we train our professionals into differentiating the TBI, the consumption of tranexamic acid would be increased. The H stage. So first of all, we examine and to manage the head trauma, so all the bleeding, all the open trauma of the face, and scalp, and neck, and we discuss this all, but we don't speak about MTBI. Again, when we talk about the TBI to our students, again we train them into mainly in the open TBI, as you see with the neck and the headsets. So again, let me stress upon that this is the minority of our patient will look like, but the majority will not have such a picture. So then we have to train our medical students into the so-called what are these red flags in the sense. Okay, Carty, chief of medicine, words. So he said, in case we would treat everyone who needs treatment, we will get no one to fight. So, but we have to talk constantly with our evacuation in war doctors. We have to explain about what is CBI. We know all of this, and now please launch a video. So what to do here? What to do here? He's losing the conscience. He has a concussion. He's losing the conscience. This is the majority of the patients about whom we have to talk, and we have to train our doctors into how to deal with these patients. So what can give us tactical medicine before admission to hospital? So this is a question to the military doctors. First of all, to take off their arms and armament. Okay, yes, first of all, the safety is above all, but then how to treat? Benzodiazepine? No. What we can do? Sibazone? No. Line injection? Okay, good idea, yeah. But we don't have any guideline how to manage this patient, unfortunately. We have this so-called our raw one, let's say, impression how to deal, for example, to throw some water, but we already got the water in the ear. He will have this is possible inflammation next to, but okay, first of all, let's say we have to take off the arms and the gown, and then we have to know how to treat them and how to evacuate such patients, where or not we will risk our evacuation and to lose the whole team in case we try to evacuate such a patient. So we have to think about all the process of evacuation. Maybe we have some means and methods to give him the aid on site, but we have to first of all to talk about it during our medical students training. Now, do's and don'ts in TBI, hemodynamics. It's rare we talk about the brain perfusion and to keep up the systolic AP on 100, 110. Then, but first of all, we have to measure the AP, but we have to explain to our doctors, I mean field doctors and our evac doctors, why they need to keep up the arterial pressure on a specific level, how to transport, in which position. So we have much better means than dexamethasone, just to raise the head of the patient, but not to evacuate him in a sitting position. So next, so inline injections, first of all, to raise up the arterial pressure in case only on the condition that he has no shock. No. Next, hyperventilation. Not all the patients with TBI needs hyperventilation. You have to explain why it doesn't help, it doesn't work, why you should don't do this. So in a pre-hospital, we don't have any means not provoking acute nausea. Say with only the specific like mask plus a bag, but nothing more. Yeah. Otherwise, it will provoke vomiting and nausea. Say ulcer damage. First of all, if it is open, so we have to cover it. Antibacterial prophylaxis. This is taken from MOH guideline. First of all, the ceftriaxone, artepanem. Unfortunately, we don't have it. We have a good guideline on antibiotics, but some of them we just don't have. But whether or not we will inject antibiotics to the patients with MTBI, like ciprofloxacin, why? Pelpac, why? But such patients sometimes receive such medication that is not needed. So how to, let's say, to mitigate the symptoms? First of all, to work with nausea and vomiting, since it's the most common symptom. And then, in case we talk about ondansetron, so it's in priority than the metoclopramide, and mostly the not in injection, but mostly in the pills. Pain relief, paracetamol and ketamine. What we have in our kit? What can we use? Paracetamol? No. Ketamine? No. Why not? But it's really painful. Ketamine was chosen. Why? Because it is allowed for TBI patients, but now we have to stress upon that not on all the means really, let's say, make this disaggregation of the thrombocytes, so we can introduce here ibuprofen as well. Not talking about opioids, we will not use it for TBI. We have one of the study that the early pain relief prevents the PTSD development. That's why we have to really put an accent on the pain relief and to seek for the alternative options in case the forms that we have don't work.
So infusion is like by people who don't want to have IVs, but patients say do that because nobody knows that Infilgon is paracetamol. Infilgon sounds very good like the anti-concussion thing, so they use it for IV. Okay, so I put nothing here because it's not for battlefield medics. We'll talk with our colleagues about that, but okay. So now we'll talk at the panel discussion about 3 hypotheses, okay? The pill pack for concussion, okay? What can we have? Like a certain package of pharmaceuticals we give to all people with concussion that will be super frequently used, because according to statistics provided by one of the panel discussion participants, these are all like this state secret. We won't say who that is. But yeah, so this head of medical service of the brigade told us that more than a half of all patients supported by his medics the mild TBI patients. So this is a gift if we give them some good pill pack. We'll have a discussion on pill pack, what can be there. Will it be a functional thing? We'll discuss the headsets. Yeah, maybe this is a solution for us to have thousands of 20-year-old guys saying, what? Like, yeah. And we'll speak of the super provocative stuff, that the only treatment against concussion is mass mobilization. We'll talk about that. So, yeah. And I want my wonderful colleague, Ms. Agar. Please step in. Thank you so much. And yeah, I guess this. I actually share the clicker with you right now. And we have with us Agar Artsimovich, who is the therapist of the 12th Brigade of Special Operations, Azov. Yeah, so thank you, ladies and gentlemen. I haven't been so like long for at medical conferences, and I want my conference to where should I click to have it elsewhere? Okay, everything works. Yeah, it's there. Great. So no drops or no IVs. So this is the most frequently used statement at my appointments. All servicemen who were evacuated at some point. So this may be a short term, like immediately from the after the trauma or in 10 days, different tactical conditions we have. So almost everyone says, I need to have an IV. Okay, I had my pill pack, I had some rest, like 7 days were there. Okay, I need to have some proper treatment. And we say, we don't do that. And they say, like, why? In all brigades you do, but in this you don't. Like, what happens? But, you know, to get to the root of why, we'll speak a little bit. Okay, as Dr. Lee already spoke, okay, what is considered to be a concussion? Like that they will revise this, that not 50 but 75 meters already. We frequently see that this is mostly 1 to 5 meters, yeah, of distance. We'd love to speak of those, but not of 75 in distance. That there must be a witness. It's good that we have a witness, but when there was one person at a location and just tells, you know, like, okay, I have an injury, we say, no, no witnesses, and that's it, like, you're healthy, stay there. Should we do that? Again, American recommendations are really cool. They're well, thoroughly processed, a lot is invested, but it's not for our warfare. Partially, we can use it, and we rely on that, of course. Okay, so we have this gravity level for TBI, yes. So people have a statement that this is a mild or grave concussion. Okay, maybe that there is a mistake on the slide, of course. When we speak about concussion, we always speak purely about mild TBI, okay? And the criteria of recognizing, it's like a not heavy loss of consciousness, not so heavy alteration of consciousness, not so heavy post-traumatic amnesia. If we see that it goes beyond, we don't speak of mild TBI per se. And we have another scale for gravity evaluation. Mild or grave concussion, I think it's incorrect, so we don't use that. Yeah, this is a bad slide. Okay. Okay, red flags, as Dr. Lee said, yeah. And Maria, we don't stop here. But, for example, if the combat medic, due to different reasons, cannot evaluate it. So if we can contact with the patient, if one's accessible, we talk. We ask if something happened, if what happens to you now, and minimum neurological examination by ourselves. Okay, there was tremor. So we stole it from another source. So gradual return to activity after mild TBI, almost everything in the scheme. If everything's okay, you can do it at the stage of medical service in the brigade without sending to experts to the next level. If we fix it, if we provide adequate, if we have the adequate management, if we do it via the protocol of activity return, if we do it instantly, and the protocol we usually have like at the position, you know? What can be done at the stage of medical service? Okay, according to algorithm presented by Deployed Medicine Portal, we of course, first of all, the acute headache, yeah? This is one of the key complaints. Pain and something's wrong, as they say, not as always. And this is how the protocol starts with paracetamol. Masha spoke of, we call acetaminophen, we call that, yeah. Okay, acetaminophen, 2 pills, 3-4 times per day, and everything's gonna be fine. So we delay, yeah. For 48 hours, yeah, if there's some internal hemorrhage, yeah, maybe we do not need to put the acid. Ibuprofen will not help the thrombocytes to just come back. Okay, we're trying to stay under the protocol. It's okay. So acetaminophen, and we say that if it doesn't help, another examination will change the therapy. And we really love the protocol of management for the headache, because there are many stages. It's multi-stage. If again the patient comes, you can pick an adequate therapy, but the key thing for these patients to come to us again, but not as it always happens or frequently happens. No IV, he's offended, he never returns, okay? Okay, what can we actually do with consequences of mild TBI conceptually? I think everybody knows that with we don't use so many pharmaceuticals, we can't even use that. It's the pain management. It's about managing the comorbidities, blood pressure, and basically that's it. All other measures will be aimed at neuro rehab, and of course other people will tell more about this, but we're coming back to this issue. Okay, concussion IV, pro and con. Okay, so all of them actually won this, and there's a big fault of doctors, of all of us. We are to blame. Not personally, maybe, but medics per se. Those who for years, for decades, are putting this in heads of people, the concept, if you don't have the IV, it's not, you don't get the treatment. I really want to remind everyone that IV is just a method of transferring medicine to the body. It's not a magical one. Nothing changes when you take it orally or like, it's the same thing. It's like in advertising. The cough syrup doesn't go to your lungs, but okay, the pill works. Please don't use the IV just because the patient wants that. We have this practice, put something, like give some physical solution, an IV with vitamins for him to feel that one is treated. I know why people do it, but we really want to break this vicious circle, stop producing this doctrine, nurturing it, because as for me, this is not okay. When 20-year-old guys just use their grandma's statement saying, I need an IV, I need to clear my vessels, I need to have some rest. No, it's not. It's not. This is 2024, people. Okay, what are the cons? So it's always invasive manipulation. Even the tiny one, the minor one, still there might be some flip beats and you know what happens with vessels when you use some of IVs? Yes. Even if they say that there's vasoprotection still, but endothelius, we know the problems with it. Okay, basically no advantages from the pharmacokinetic point of view. Pill is smart enough to find the way. Quite a doubtful choice of medications we have for IVs. It's not normal. Colleagues, when person comes with this list of 10 medications, and I hope that 3 of these at least to be functional, conceptually, not even for TBI. And again, if we start counting money, just if we buy ineffective medications, instead of these, we could have buy tourniquets, yeah? The venous operator, as we call them, the one is distracted from other injured people. So, yeah. And something we don't use for IV. L-lysine that the cons. It doesn't have any pros, but only cons. It's not evidence-based. Yeah, that's a coincidence. In the instruction, basically, we put something in the body, and we don't even have those guidelines. We don't even understand what the dynamics is, how it's taken out of the body. Nobody studied, the whole process. Local side effects are manifested, and also the price of one item is approximately of the price of the tourniquet. Vinopsatine. So quite often we can see it in others' prescriptions. Really interesting description of it, in the guidelines. If you know what it's doing according to instruction, please tell me. because colleague from my brigade cardiologist, he doesn't know. We asked in the heart center, they don't know. If someone knows what kind of function that is, erythrocyte deforming, so it goes better through the vessel and then again turns into disc, like what does it make? So there's an interesting story with the complaints in courts. It happened in the US. But when some producers of supplements added this, telling that it improves the brain function, there was a huge compensation case, in the court. Yeah, so precedent. Okay, that's a nice thing as well. And the FDA declined official one. It's there. They don't think it's safe. We read this letter from FDA, but again, for us, it really works, because it helps the brain. Why shouldn't we? Clean. It's like a younger brother of others. Also very expensive, not evidence-based, and even a little bit of negative. These are the medications that we strongly do not recommend. Okay, something that we do respect, but the aim of its prescription, why we use it for mild TBI, we don't know why it's used. Dexamethasone. I'll tell you instantly that I've been in rheumatology and I worked a lot with hormones. Nobody can blame me for being afraid of hormones, that I don't like it. I understand why we need them for, but you all know that when we have grave and moderate TBI, basically these should not be prescribed. It leads to high mortality. So, mild TBI, is there any brain swelling? Like, what are we? People say there will be a swelling. Okay, if not dexamethasone, some diuretics. Why? Where is it? Where is the swelling? Is it swelling actually? Do we need to put something for the patient when it stabilizes by itself, the process, when you have some external impact, not the internal one? Alrighty, so all these medications, when we ask, why do we do it? Neuroprotection. What is neuroprotection from the standpoint of science? This is the strategy that must impact directly the tissues of the brain. We know that the vast majority of molecules of medications don't even reach the brain because there is a barrier. Even all the medics, all the medics in our unit, they know this word because they love it. They know that this barrier exists. So many medications, we don't have proper instructions, but we say that they affect the tissues of the brain. That's really brave to say, Okay, the perfect medication must be always active, something without really harsh side effects. So handling the barriers, certain specificity, and actually reaching the place where the process takes place. I stole this, actually, the statement from the boys. So when we speak about neuroprotection, we need to remind ourselves that one of the most effective neuroprotection medicines in neurology, as far as I know, levodopa, and 98% still does not reach the brain tissues. There's no effective neuroprotection medicine now, which could be used just as a magic wand for people with mild TBI. It's mostly not about medicines even, okay? It's not mostly for the medicines, but thank you for your attention still. Thank you. Yeah, that's a very painful issue. I have to ask this question. Okay, what's the thing? So we have to stand one front with these IVs. It's not just about combat medics or doctors. It's about psychologists, those who we have in units. Because people, especially military, were certain mental condition, with their constant alert mode. We can't just say you can't do it. We need to have this awareness raising. It takes a long time, it takes so much time. We have to explain. Sometimes make a scheme, draw something. I draw something for my people because you visualize, you tell where it reaches, where it doesn't reach. It takes time. It's your investment eventually. It's really hard, but if we do this, in a structured way, systemically, maybe in 3-5 years, we will like change the stigma. And it goes for many even civilian diseases, like people with diabetes or hypertension. They say, oh, I need an IV once in 6 months. So in our forest glade, all our psychologists and psychotherapists like handle they educate others because it works. They educate the colleagues. Okay, you want to have this IV and you need to put a photo on a Facebook that you have an IV and send it somewhere. Then for people to feel like, okay, this is a real treatment. Let us all be in this fighting this invisible enemy, because we have to fight this as well, okay? And we continue. Yeah, we definitely continue. Maria, please take your seat. I'll ask people who'll talk to you, because you said first the overview and then the discussion itself. Okay, I'd like to have with us now, for the second panel, Head of Medical Service of the 3rd Assault Brigade, Victoria Kovac, please. Okay, we have also Andriy Kostusov, Head of Medical Service from Khartia Brigade. Wonderful, yeah. And actually, the Fantastic Four in offline we have here, and with us, I hope we'll have online 15th Mobile Border Guard Detachment, Steel Border. Alexander Solovchuk, head of the medical unit, will be with us. I do hope. Okay, let's ask the technical team if he's with us. Alexander is with us. Beautiful. Thank you. So, friends, okay, we have these microphones. We'll have super active discussion. I will not even invite you. Grab the mics. Those who takes the microphone, he speaks. Okay, this is the standard thing for the conference. Hello, Alexander. Do you hear us? Wonderful. And please interfere if you want. Okay, good. And yeah, he's a great doctor. Okay, he even used to be a great doctor before that, but now his medical opinion is very clear, very proper. Alexander, I love you. Thank you. The same goes to you. My love goes to you as well, Ksenia. Okay, so we had a very cool report from Ms. Agar on how they do it in their brigade. So we speak of the pre-hospital stage, where we don't have to get even doctors, yeah? We have to talk to heads of medical services we have here, like from 3 cool brigades, large brigades, and Armed Forces, National Guard, and Border Guard. We have to speak with the heads of medical services. They have to bring it to their subordinates. One joint idea concept. No IVs, or let's say we have MACE, or let's say we have the protocol of gradual return to activity. I want to start with a question to all of you. How do you call this? Because quite often we face this, that we have different names for this mild TBI, MTBI, yeah? Of course, we mostly have concussions, yeah, the word concussion. We even argue that this is not properly put in Ukrainian, that this goes for the intense care then, but not TBI, acubare traumas we have, okay? So a different diagnosis, something completely different. We cannot even assign, no, even not all doctors are entitled maybe to confirm this. And what we have, the cephalogical syndrome. And our medics started like being very loud, because we have this opinion of so many combat medics that this was invented specifically not to put people to treatment. This is like a false diagnosis. Acubare trauma is real one. You will have treatment. Acephalogical syndrome is like when you have a headache, for those who don't know. So I just want to know how you call it in your brigades, like something that we're going to talk for 2 days in a row, okay? How do you call it? I think I'll start. Okay. Hello, ladies and gentlemen. Well, first of all, thank you for raising this issue, because that there are people who don't realize the scale of the problem. This problem now is just under discussion. Let's say it's just discussed, but in 5-7 years, this is going to be a very tangible and palpable problem, like for all specialties, for all areas. Like MHGAP, we teach primary, secondary, and everyone. For MHGAP, we will teach everyone how to work with these late effects of TBI, patients who stay within Ukraine.
And I think that we will teach also are doctors, I mean abroad, trying to adopt the overseas experience. Now let me start with syndromes and diagnosis. Those who have medical education, they know that there are three categories of what we fix as description in history of disease, symptoms, syndrome, and diagnosis. 3 points. And when we have the diagnosis, so why should we specify the syndrome in there? So then base in case patient is complaining about some specific symptoms like pain, I mean the symptom is pain. Okay, pain and other symptoms can form syndrome, and the syndrome they form a diagnosis. And I don't know, I don't understand that again when in the front line or already in the hospital, we voice up the not the diagnosis by a syndrome. So why we hospitalize this person when we just specify a syndrome. And when we talk about the war trauma, and plus this is not described from the history of disease, this is a specific document, let's say evidencing all the facts of the health condition that is needed for some category for financial aid and so on. And we also have to specify why and how the person got this trauma. And not the syndrome should be specified, but a diagnosis. And that's why, from the point of view of a medical team, plus my 9 years in medical university, so I think when it is a field of in a document of a diagnosis, so we have to specify the diagnosis, but not encephalic syndrome, not specifying the word syndrome. And again, when at stop point, we specify blast trauma, and then what is specified in MACE protocol. So why we have to specify the blast trauma, since it's not like some civil accident, plus it's a characteristic of the trauma. And then depending on what we have with a specific patient, so whether it's a severe or mild TBI, so where that's and all the specifics, they already are specified in the second stage. So from the Veteran Commission, as a member of Veteran Commission, I would like to again to argument that some data are not specified on this step point 2, since who's making the diagnosis, the GP or neurologist. We don't need any neurologist in the stop point. He or is the neurologist can intervene later on. And who are you? A pediatrician. So I mean that the person is competent when, I mean, as a doctor, when he got neurology as the course. So we don't need, that's why we don't need a neurologist on the standpoint that since a therapist already has the neurological training. So again, I would like that this form number 100, so we specify the acute trauma, TBI, since these two data, this data is sometimes missing for the Veterans Commission. Andrei, what are you doing? Thank you very much for your invitation. I've been a psychiatrist, so we can uh, describe it or specify it in a syndrome, in a way of a syndrome, like encephalitic syndrome, um, concussion, plus in combination with CBI. So we specify this in a descriptive field of description. But okay, let's give it a name and the algorithm. Since we're here to develop an algorithm for a primary or maybe a secondary treatment for such a patient, then we have to differentiate a severity even within the MTBI. I mean, in the sense that the subconscious doesn't tell the soldier that with the treatment he will get better. With a specific treatment, he will get better. In the sense that the patient should be treated, whatever it's stage 1 or stage 2. That anxiety and phobia syndrome, for example, or so on. So, but why don't we specify just about TBI? Well, the neurologists, they prefer the longer diagnosis, not just one sentence. Okay, we put these 3 forms of trauma usually. Okay, let's say we're seeking for the name, but first of all, we have to identify what do we treat actually. Is it a syndrome that can be resolved with some pills or so? Everything is quite individual. Everything depends even on medical specialist who does the examination. For example, the patient can say, "Oh, just leave me. I will lie down for a while. I will get better." Okay, but it's good, but not for everyone. It doesn't fit for everyone, I would say. Okay, yes, human factor always will have its effect, but quoting use that in case when we treat everyone, there'll be no one to fight. Oh, no, no, no. It's just taken out of the context, but it's true. It's true. So again, please, Alexander, share with us how you deal in within the so-called steel front line, say, and what do you do with those who come to you with after the big blast trauma? Thank you for inviting. It's a very important topic. The topic that is not yet have been, let's say, discussed in a due way. I never met like a mild traumatic brain injury as a diagnosis. It usually is open or closed. It's rare to have a patient with MTBI. And again, we created our own team. We got lots of civilian doctors, those who've never been involved in military medicine. And again, when the question arose, what to let's say, specify as a diagnosis, there were many mistakes in, let's say, biases But next to, yes, we just, let's say, we learned on our own mistakes, and plus with CaseEvac, Medevac, evacuated patients. First of all, yes, when we see a person with a blast trauma, so we specify blast trauma, and then we describe the clinical picture, and usually we put them the trauma. Usually, why? I don't know why is this trauma. Since the majority of persons give or present the same complaints like vomiting, nausea, dizziness, and so on, I got the problems with filling up the form number 100 since we got many patients evacuated with already specified diagnosis, and you know, the previous doctor put everything he knew in the diagnosis, so we tried to rewrite the form or to correct this statement, in particular when we refer the patients. For example, we don't have otolaryngologists in our team. For example, when we got the patient with trauma, we also try to correct. We have our own template to fill in, and so we try to be as specific as possible to describe the diagnosis and yes, we have to elaborate some practice and to propagate it to all the squads, to all the teams, for the persons to understand how to feel, what are the criteria, what to write, how to describe. Thank you very much. So what we can specify, first of all, is the leadership. Yes, to develop a leadership within this area, to be more somehow uniform in treatment and diagnostics. Next, usually put MTBI almost to everyone, in particular infantry. Yes, and it's true, they will have it. But how to deal with those who also need medical help, medical assistance, and who really need the interventions at the very first stage? So how do you train your doctors, namely on the medevac, who really needs the evacuation, who needs the treatment, and which one? Let me start with this. So again, in there we have also human facts, in the sense that the evacuation is provided by the medical division and various detachments, and again, the heads of these divisions and detachments, they know their own team and the individual features of the patients. Since one of the patients with some small laceration on the finger will cry, "Oh, I'm 300, 300." The others, even with the several fractures, will stay in line. So again, we have to train our personnel how to assess and identify the amount of trauma and who really needs the evacuation, since our task is not just to fill the form in the right way or to use right words and to use the right way to evacuate the patient. We have to return to duty as best as possible are war fighters. And my own idea, so taking into consideration that these 75 meters from the explosion was no difference as a mine or gunshot or there's a shell. So since we know the difference of the like caliber 80 or caliber 120, but we have to develop a concept, like in case we see a symptom, such as symptom, okay, we have to deal this and that way. For example, the question, what is the symptom that really differentiates 100% the MTBI? The MTBI is differentiated by a simple fact of the war. And since when you see the nausea and vomiting, that's already MTBI. But if it's a phobia and paroxysmal psychiatry, you will see the nausea and vomiting? Yes. Sorry, I'm not a psychiatrist. But and in case we have to identify who's just is eager to get out of the war, and so pretending he has vomiting and a trauma. Do you have such persons? Well, I've never been faced up with that. But in case, for example, there were no witnesses of what has happened to the soldier, or for example the soldier comes after several days and saying complaining of nausea and vomiting, but we don't observe for example the causes, specific causes to specify this diagnosis. And plus, every soldier has a lawyer. They call to a lawyer, and the lawyers are also coming into discussion. So, no, okay. And if in this, how to differentiate the case when a person just aggravates or over aggravates his conditions. Yes, but there are other persons who want to get back to duty since they have, oh, my brother's over there. Well, even while meeting, he says, I'm okay, I want back to front line. Or, for example, but what to do? So, shall we put the diagnosis of MTBI to everyone who's subdued to an explosion? And in particular, your doctor is in a panic and he wants to evacuate everyone. What to do? I'm into the military medic. So in case such a doctor is calling me and asking me what to do, I say you call the wrong number, call your chief, and he will tell you what to do. Okay, Olga, maybe you say something more human. Okay, let me get back one step back. When we discussed what to do with concussions on the front line, first of all, let's split patients into two types. First are those who address with complaining within the area of active fighting, and The second type, who are evacuated but then develop such symptoms. Okay, then to whom to provide the primary aid? Again, to two categories. First, those who have specific complaints when disturbed by them by some specific symptoms, and then the doctor makes decision whether or not to start the treatment.
The doctor diagnoses the problem. So second category is about red flags. And in this case, when we do talk about red flags, who should be taught? Not only the medical unit staff, okay, but the whole personnel, all the personnel. So what should you draw your attention to when your comrade is doing it differently? One may say, I'm healthy, but one has sleep disorder. So you can see, like, at night, one's waking up, you can see that person has no sleep, completely deprived of sleep. One wants to get some night shifts, asking to get some night guard shifts, because one cannot sleep, and this is the only option. How can a person, like, spend this time? You, as the comrade, has you have to tell someone about that. Who is the person who should get this information that Andrei or Petro doesn't feel fine? Okay, so I usually try to split into categories. Those who come and say, I feel bad, I have pain, it's not okay, it's discomfort. Second category, people, if you observe that something's wrong with the person, the one that should get the help. Okay, then the question, what kind of help, what kind of care to provide? So what kind of, this is about diagnostics and level of consultation, examination. If we speak about who to evacuate, the question, okay, this is the most accurate one. I, I, I wanted to say, well, fortunately, not all of us in this room evacuated people from the zero line. Okay, thank God some of you haven't. Not all of us present here saw what acute response to stress is, but those who has seen that, the question like whom to evacuate, you won't even ask yourselves about that, because those who saw a person running or not even running or just staying silent, the person who's silent and sitting under the wall in a trench cannot speak, cannot respond to external factors. One does not hear when someone is talking, the comrade is talking. My question is, okay, a combat or non-combat unit, and when one will turn into a combat unit, returning to that reality where one is. There are wonderful foreign trainings on how to explain the colleague where you are and staying in the moment. Okay, if well, my psychologist may correct me because this is not my area, but the question is like you're here, you were doing that, and you realize, okay, you need to keep the sector. Okay, it looks good in the video. In life, it's much worse. So, okay, the bomb falls in 100 meters, and you can't keep the sector. Okay, nothing against aviation. You're just confused. You can't find yourself in the space. And whom to evacuate? Question. Never. Even for the combat medic, nobody asks that. We evacuate those who are in M113. And the next stage, they'll understand if this person required evacuation because of MTBI or not. One had acute stress response. Question. We talk about MTBI. Where is the borderline between the acute stress response and differentiation at early stage? I like that we heard for the first time from Victoria awareness raising, not at the level of combat medics even, but the comrades, for them to pay attention to like other servicemen, just how your comrade sleeps, what emotional reactions, who should actually educate the medic psychologist. Maybe some of our panelists someone has this experience. I even have my colleague sitting in the room. I guess he can tell. Please, maybe the microphone to the room, and the colleague gives the training, okay, for the comrades. Yeah, as far as yeah, let me introduce myself. Viktor Komarenko, associate professor, my code name, head of psychological service. Okay, so we also have to do that all. And the question is, well, it's clear that in tight cooperation with medical service and In the brigade, we have this cooperation being shaped, and I do think that this this trend, in Ukrainian AFU that psychologists have to be subordinated to medics, this is logical. It's a healthy opinion. It's a good opinion that now is, let's say, now it's becoming more tangible. It's being put in practice. So, in my opinion, psychological unit or service should not like extinguish a fire at some point, but preventing. It's about prevention. Therefore, we have trainings on ICOVER protocols or other ways to provide emergency psychological aid. It's raising awareness. It's about using very simple but effective things backed by complex neurobiological mechanisms. This should be our work. But the problems of psychological services, they're discredited by Soviet and post-Soviet army. Okay, but this has to be done, and we're trying to do that. Okay, tell me please, how do the servicemen perceive that psychoeducation? They say, oh, it's for medics. When before Bakhmut we were leaving the Rivne training drill, they said like, oh, everything's fine, like everything's gonna be fine. When we had first actual combat experiences, I had my first psychological debriefings after the first month of actual fighting. You know, much less of that talk was there. So when this first bridge, this first meeting I had, it will always be a lousy one, the first one, but every next one you'll have more and more trust. For example, I gave a lot of interesting information to the combat battalion commander, so he made some HR decisions, tactical decisions based on that, and of course. We were familiarizing with each other. People knew in the unit that if they needed, they could ask us anything. So it's what we call the human factor, something that our colleague from Hartia mentions a lot. Human factor. Truly, it's really important. It's a fact. And we're trying to scale up in the brigade, not very successfully, but again, we have objective and subjective barriers. The TRIM system, trauma risk management. When comrades understand or they recognize some weird changes, in the group, and it actually eliminates all these issues. It's like people come with like psychological problems, but then we detect that it's not just psychology, it's not just mental, maybe something organic, And this interaction is taking place all the time. Very interesting opinion about subordination of psychology to medics, because it doesn't look like that still, and what we have so far. Psychologists mostly investigate, but okay. I don't envy my colleagues, but again, I used to investigate also a long time ago. But it happens that in a specific brigade, perfect conditions. Okay, the third assault, yeah, the best one, yeah. We're grateful to the third assault. Thank you for sharing your experience. Yeah. This is really very useful to listen to this because, a very specific category that definitely will say, we don't need that, but colleague tells that we can communicate. Okay, friends, I want to go to maybe hypothesis. Those that I offered to discuss, pill pack for concussion. And I know that some units try to implement this. They were not ready to share the data on its use. Do we have the need to keep people without severe manifestations of TBI, keep them at positions, okay? If we don't want we don't want to evacuate, we want to treat them locally, can we give the tools? In my hypothesis on pill pack, we can use painkillers, paracetamol, maybe some non-steroid anti-inflammatory acetron against nausea because, yeah, this is quite a frequent symptom. And we tested with pilots, with the drone operators, drone as they call, when they have balance problems. And also it helps to eliminate nausea and maybe a little bit of calming down. I spoke of Sibazone because we have so many colleagues that think that the only problem of patient is not enough of trunk in the body. And they want to give some sleep to people with concussion. Is it a good idea? Can we take this pill pack? Can we consider it? Like, may I? Please? Yes, you may. I love fighting with meloxicam because this is a good medicine. It's a good painkiller, but in instruction it tells that it doesn't fit for acute pain. And I don't understand why it's still in pill pack. And me and Masha, you know, what I want to cancel, she canceled the pain shock, but I want to cancel this lowered adhesion of thrombocytes with one shot. If we take this good management protocol of gradual one for headache, maybe Proxend. I've seen some good feedback from patients transferred to Proxen because paracetamol doesn't help. Everybody knows that. Tylenol, yeah. So this is about pain killing. Maybe colleagues will share Victoria Andrei Alexander on pain killing. What do you use for concussion cases? Yeah, I will. Okay. So dexketoprofen works for everything. So for painkilling, dexketoprofen. So I love it. Okay, it's injections. No, pills. Okay, pills also. Sachet. Okay, good. Alexander? I just want to say that yes, at this stage of evacuation, yeah, dexketoprofen, something we can choose from. We have injections usually. I haven't seen so many pills, usually injections. And when we are stabilizing, or I'd like to tell again about the case, how the evacuation is shaped and how we work after the evacuation. So initially, case evac, yeah, usual thing that we have. Then medevac, stabilization station if we have patients that requiring the stabilization, a moderate injury or even a mild with some symptoms that doctors need to examine and take some measures. And after that, our guys go to hospital unit. So when we have a brigade, we have a hospital that is open for 30 beds, neurologists and therapists are there, and then we prescribe if they need pain killing usually, and also they need pills in many cases. Paracetamol, ibuprofen, and naproxen. Yes, we have that. Not that frequently, of course, because these are the key pharmaceuticals we use. But this is the hospital unit, so this is not the stabilizer. Yes, thank you, Alexander. We have some some opinions from, yeah. Can you raise your hand, Metro? Because we need a mic. Okay, a surgeon will speak. He knows everything about pain killing. Okay, we have the sound very well. Well, I'm a surgeon, anesthesiologist. I'm the head of the surgical unit, Metro Samahvalov, role 2. Role 2. The one that will tackle everything. No, one will not handle everything. I was keeping silence, but we always speak about complication of a system. Paracetamol is a bad thing. Okay, who knows me? You know that I love you because you're the best, and so on. But I work with everyone, so staff coming to me, these are everyone. Okay, these are like completely all people. Okay, if we do the actual job and you know what numbers we have for role 2E, someone with the stat point, acute traumas, I'll tell a lot. I wanted to say little, but also a lot. Those who are entitled to diagnose, I have otolaryngologist in the degree, but I've never seen it in reality ever. You know, pediatric doctor and family doctor Vadim Vus. He taught me how to have the otoscopy, but all my attempts to write it. Okay, you're a surgeon. You don't have right to write it, but I do ultrasound. Okay, you should write ultrasound. Otoscopy, no. This is for the otolaryngologist. So when I started putting SDM, they sent neurologist. I took lysine from him because I'm not entitled to diagnose with SGM. So children's surgeons are universal, work with everyone. Which surgeon you are, I say wandering surgeon because I diagnose everything, but I have no right. Now now we have a surgeon, sorry, a psychiatrist, because again, acute stress response, I'm not entitled to diagnose this. Who is entitled? The first thing, yeah? Second, if one will handle it. When we have actual job done, I have one therapist and everyone else, all other surgical specialties. I had also dentists, and they were amputating limbs even because we needed hands. They will not handle ocular trauma, mild TBI, and so on. Sorry. If a brigade will bring a person to me, and sometimes in my reception hall, I have people from the brigade, they look at me and say, we're taking this one. Don't take him. But if they leave the person, one will get certain treatment with the simplest protocol and move further. Because for all 2E, when this is a huge number of injured and people with traumas, we won't have time to handle the maze and figure out the maze. Sorry, third, paracetamol. Any complication of the system aggravates the results. If I know that I have people who took pill pack, I will give them treatment of the following stage. If I try to find out if they get antibiotics, there will be another examination with the same March thing and so on. But quite often it happens so that I have had this case when I had ocular trauma case, and that was a liver injury with mass hemorrhage. So because hemorrhage shock, one of the first symptoms, especially for kids, pediatrics know, the first symptom, it can be the cognitive deterioration. You know, when I had this case, dark spot, you know, I was delivering as a professor in university and I asked students, what is shock? And someone says, pressure goes down, something else, something else, something else. If a child with shock, if pressure goes down, in the end of your working day, you won't do anything. It's not adult. You won't do anything. But problems with conscience. And yes, I had cases when there was an adult person with shock, but ocular trauma diagnosis, yeah. And you have to handle it thoroughly. If he got the pill pack or not, IV or not, what was in the IV. Acetaminophen, okay, there's a dosage that is toxic. Injected or not. Not always, it's... So, why am I saying this? Okay, unification, logistics, and nobody will reassure me. Medical logistics is more important than medical skills, guys, because, yeah, if you want to have dexcatoprophene for everyone, then in the decree, always only this, no exclusion. But if this brigade brings patient propofol, I had that as well, and I cannot understand if one in a shock or this person is under the propofol, or and he tells, okay, you have the sensor, the pressure goes down, put the shock. So for me, it's really more important. Maybe it's super not medicinal, but for me, it's really important to have logistics, sequence of stages, and standardization. Then which medicine is better? Paracetamol for everybody, instead of like this one gets ketamine, this one gets other, this one gets something different, and we had and lily pops and yeah, that's what I had. So he's like, and someone got the atropine, and yeah. as British say, you know, blind and red and running and crazy. You don't understand if this is the trauma or he is taking someone of the darkness. If imagine if you have everyone at roll 2E and 20 people are running in the darkness, you know, like it's about these sedatives. Yes, I also say to standardization. So you've seen how the pediatric doctor turns into a military doctor. Okay, I was a professor at university. I just needed money. I was young. Okay, I wanted to interfere. Okay, good. It's impossible. It's impossible to interfere with your speech. Okay, standardization and level of responsibility. Look, the head of surgical unit tells that he can do something, but propofol, at pre-hospital stage, you can. You know, giving some substances and not even putting in the 100, yes.
So it's all about us in the pre-hospital stage, because we were not told to what to do by our medical heads or, let's say, combat heads also didn't tell us. But on some point, people want to give some medical treatments, some medicaments, and we want to control the consumption of the pharmaceutical products. So please provide us more recommendations of what to do. So maybe we will continue the discussion later about so-called pill pack. We have another hypothesis, but okay. Sorry, the mic is not used. But we can fight over, so please be quite attentive. So, about the headsets, we will talk a little bit later in occupied trauma. So, again, about the general mobilization, we cannot treat the contused patients until we have the human resource. So what's the resource you need for providing your concussed patients to stay within let's say, on IV line and in dark without any smartphones. But I've seen other medical points where they got IV line and right after smartphone and cigarette and so on. They say the IV line doesn't help me, so I need to smoke a little bit. So how to replace our war fighters, whether or not you would send them for some specific condition. So yes, the best treatment is general mobilization, and the staging like for 7 days or 15 days staging for treatment for a part of our, yes, for a part of our concussed persons. We would like to have these 15 days since there are guys who, with 3 concussions, they still stay on the front line. But maybe to get some sick leave or no, it's not an issue.
Що про це знаєте?
Да, ну ви знаєте, навики лікаря ФРМ.
You're a physical therapist, yeah? Yes, I'm a physical therapist, but we are not rehab, and the rehab is taken quite skeptically by the combat commanders. How to raise up the discussion about the treatment guideline, namely the MTBI for the unification. I really support my colleague that this is really true what she says. It's a problem not only in doctors, since they can be quickly, or is it, let's say, specified, but it's really hard to explain and to prove the, let's say, the what to do. And since there can be artillerists or different specialties and different, let's say, range, but even with the total mobilization will not resolve the issue until we manage to bring this problem to the understanding by the commanders, military commanders, in case they see the soldier. Okay, they say, hey, give him back to me. He can fight. He can fight. So, okay, this is really great, but we have here only medical professionals and psychologists. So you told, Victoria, you told about the long-term effects or late effects. So what can we advise to our civilian doctors on how to manage post-concussive patients? I would start with a kind of trivial thing. That's it. First of all, communication. The communication skills among the military and among the civilians. So we don't know. Let me correct myself. So the MTBI, in case we talk about MTBI, so it can happen at anyone. And in case the person comes already without a military uniform, it doesn't signify that this person didn't get or didn't survive after MTBI. So, for example, usually when we see a new patient, we always consider that it can have hepatitis C or HIV. I mean that we have to take maximum safety rules on a reinfection or self-infection, and so every single patient has to be assessed. I mean, war veteran, it should be assessed as surviving after MTBI as minimum. And when we really will learn how to talk among ourselves, so communicate among ourselves and with others, as we will get rid of many problems. First of all, we have to know how to bring our own idea and how to communicate with the patient, not to become an enemy to patient, but rather a friend, to be rather a friend. And so we have to teach everyone, starting with the nurses, primary line, primary care, secondary care, so administration, and so on. So with the registrars, for example, such MTBI veteran, first of all, will meet the registrar and then a nurse, and only afterwards a doctor. Nobody taught us communication, I mean, like medical communication. And one topic about how to, let's say, to bring the bad news to the relatives, it's not a communication, since the majority of the problems is that due to the lack of skill, how to explain your work and what you have to do in your service. So first of all, we have to start teaching our doctors how to name a problem. Yes, not to say, yes, it's a concussive one, say, to get rid of the concussive. Okay. Or concussed. So, and again, I suggest to include an item of establishing some specific questionnaire. For example, to include a question whether or not you've been 50 meters from explosion or less than 50 meters. No mic is used. Okay, I can bring these questions on the screen and for us to discuss it. Thank you very much, Victoria, and a big thanks from our center's mental health center. War veteran mental health depends on really on many persons, like the registrar. And let me cite William Osler, that was the first internist who brought the students from the lecture hall to the patient bedside. So, and he was the first to tell, so listen to your patient, he will tell you his or her diagnosis. And that's really about the case of multiple sclerosis. Never one no one asked, for example, the soldier whether or not you got a blast trauma. And namely, this soldier, this veteran, didn't have any documents proving the blast trauma survival. And namely, this trauma needs even more communication rather than medicaments. Okay. So we would like all the people to be informed what is MTBI. We want our personnel to duly treat such patients, to provide them with the sick leaves. And I hope that we have 2 minutes for questions from the audience. So, namely, the Form 100 discussion. So, my question is, what can we? So, we're talking to Tactical Medicine Committee. They're developing the best manuals. So what we would tell them about the MTBI, considering that TC3 is written based on American experience, where there were no so many concussions and cluster munitions and so on. And so what we would like to include in the guideline about concussion. First of all, welcome to Ukraine. I think this committee is closely following the statistics of what's happening in Ukraine. And I think that all say it will be corrected and expanded, and namely after our conflict, I hope, or its end, since no one knows how long it will be. In Ukraine will be the driver for these changes. Alexander, not always in Ukraine we can get the statistics. I'm not talking about sharing the statistics with foreigners. I really doubt about the opportunity to get good statistics. Well, I told it that there'll be some time when they receive. First of all, for us, to really have the timely treatment of those who come to us. Yes, we have to mobilize more persons in order to treat better the MTBI. Mainly is my let's say, wish for the Americans to work better with non-compliant patients, since when a person went into army, they always say, yes, sir, in jumping on one leg, jumping on other leg. But when it's, let's say, not a standardized army, when you have people with different intellect, different age, well, it's really hard to standardize, and we have to know how to work. Nevertheless, we have to work with uncompliant patients. Thank you. Quite fresh idea. Yes, army better is better than you're describing, but nevertheless, uncompliant is a new, let's say, wording. We'll talk mainly about neurological phenomenon, but let me talk. Let me speak out as a neurologist and labor therapist. Okay, yes. When I first heard about benzodiazepine, I went sick. Why? Again, when speaking at neurologists, when this is a neuron that has been really inhibited, plus you give him the comment as just to sleep. So will it survive or awake? I never heard that sertraline and nibizine and the only single one MDA receptor blocker, memantine. This combination is working quite well on discriminatory impairments and also with the senile symptoms. It works well with let's say for long distance, so-called long distance. When less to take memantine less than a month would be no sense, but for long-term treatment is really good. So your patients receive such a treatment? Yes. And who pays for it? Well, first of all, the state, yes, from the state budget, and also we have the volunteer help. Those who don't have the volunteers assistance say, throw a stone. So, yes, this is really great. I wanted to shine it too much earlier. And again, why don't we talk about cerebralism? Okay, let's talk more detail in the panel about acaparatram, where we have sertraline, cefacalin, elalizine, and there's a substitution to dexamethasone. We will discuss it during this panel. Thank you very much, Andrei, for your comments, and Oksana Gorchinska. Oksana, please, your comment. Welcome. You know, for me, the war lasts for 10 years when we created the first point that we have to establish without any military doctors. So I would like to say that the form number 100 yet not was in legislation as a document. We got another template also to fill in the effects of the first wave of the war. For example, we've got a patient with heavy TBI, say that is not, say, without any proofs, since there were no templates to diagnose it, but we have now the legislative provisions to document this, and our form number 100 and other documents that we have to fill in. So it's really very important for all the military doctors to identify this and to specify this. Why it is needed? Since, first of all, you have the right diagnosing by the features that you see.
Okay, so a doctor that we had for 1.5 years as otolaryngologist in our unit, at our station we didn't have the military one. It's also a conflict between role 2 and role 1 that you bring people to us because they need professional help. And role 2, always the commanders of brigades and other commanders saying, why you have so many people with concussions? So don't put accurate trauma, okay? I don't know who told it them, but so they call to me, to coordinator, to our colleagues, to our doctors, and say, what's the problem? Okay, what's happening? It's a difference in units. I remember Azov in 2014, they did not even like get this diagnosis. They told us, okay, give us a pill, and they ran back to Ilovaisk. And I remember people injured in 2014, Azov commanders, when they entered my sector, I asked them, and they knew that they at least should bring these people to us, and the 100 form should be there. If we don't do that, if it's not in the combat log, then proving that servicemen got this blast trauma, it's impossible. I hope I will be still alive when representatives of Medical Forces HQ and we have also the Military Medical Commission people have, for them to start talking about it. Not the Korchinska only, but them will do it. Why for them it's important for 100 forms, but these forms 100 at initial level, to have these diagnoses put there, like MTBI. This is important. Because when it comes to logic, at hospital stage, then people cannot even prove. Since 2014, 2016, they still cannot prove it happened. Then commission tells you, where is the proof that afterwards there wasn't any hits in the head and like at the level of medevac and I understand that you won't have specialists, and we at Role 2, we can have some specialists because we always had this problem. They told us, why your anesthesiologist is diagnosing this specific thing. Like, for 1.5 years, he couldn't. So I now even have a neuropathologist, with a PhD, wonderful person. 12th Regiment loved them. He taught the guys actually how to use acupuncture, but they were listening to it. So it's really important now. Form 100, it's really important. Combat trauma, when it comes to these typical diagnoses, it should be there. So in 10 years, you've all seen, we have a generation of commanders who grew up and they know that these combat traumas give harder consequences than even the moderate and minor injury. Please remember that. I think we all agree. So it's important. Please, you should have it in the Form 100. For the commission, if you don't put it in the form, so Avicena remembers that. So we were prohibited to put the consequences, Who did that? Who prohibited this? Who can prohibit? We had these prohibitions. I could actually, I can give a response to commanders, but doctors simply cannot. They only get tasks. Like you are not entitled to send all these people. Now we have already units with medical components, they can have it. But we have so many in territorial defense, the situation with medics, they can't give treatment to theirs, okay? In my sector, I even have a territorial defense brigade that gives 3 days of rest without phone. Territorial defense, I didn't expect that. At their expense, they have these underground stations, yes, without volunteers. But these are exceptions. There's no system. I understand our colleague who says that, guys, yeah, all specialists would love to have unification. Because otherwise, every time you'll be like a pioneer. We quite often use our volunteers, and it's so different. Our medical units were not licensed. They had no access to narcotic drugs, and volunteers were bringing something. It was fine if they did. Not all medical units even got the licenses, okay, but you all have it, okay. You all have the license, border guard, yeah? Yeah. Special save boxes we have. Yes, we have. Everybody has the save boxes. We dream of this for everyone to get those save boxes because propofol, you understand. We brought a lot of this. Yes, people were bringing it that just yours started, and so just to finish with. Form 100 is important. Diagnosis is important. The next stage, please. So, if we have a person at station, a civilian, for 1.5 years via the international organizations, we have those units that can allow it. We can allow it. Many simply cannot. It's not affordable for them. It's not even about combat medics. And with the number of injured that we take. 4 6 surgeons, 3 anesthesiologists max. Please, Miss Oksana, we heard you. And 150 people per day. We speak about rain. People need to have lunch. Yes, it's glucose, yes. Thank you so much, Miss Oksana. Three questions we have. Unfortunately, we don't have a microphone now. I'll answer the third one, okay? 1 gram for paracetamol once per 6-8 hours standard dosage for adults. Second question, I guess Andriy spoke of that human factor. If cephalogical syndrome gives pain, then it will, give the result.
Ну і там ще є якесь там, я знаю, злоякісне пароксизмальне вертіго, теж
There is some kind of
відомо.
vertigo, nausea, something that I know. Yeah.
Так, і чому не можна ставити СГЛ? Вікторія, напевно, знає.
Okay, Victoria maybe knows. I didn't read those documents which tell that there is no right for this to be put. To my doctors? Okay, there's no such.
І, ну, той самий цефалогічний синдром, якщо я
The
його
cephalogical syndrome, yeah? If I see it
листов,
in Form 100, I offer the head of the medical station for the patient to verify the diagnosis at a higher level.
ну, є приклади, коли просто діагноз знімається.
Sometimes the diagnosis is like canceled, the patient is consulted, and neuropathologist and otolaryngologist consulted, and then it's fine, okay, if it comes with a concussion. So if only the cephalogical syndrome and then with concussion, they brought him to hospital and so on. It must be an individual approach. There's no standardization. Okay.
Одне питання ще від пані
Okay,
Фортуни.
one more question from Fortuna. This will be the last one.
І, на жаль, ми просили трошки такі
We
швидші
don't have
слова.
time. I am a combat medic without education. You diagnose. Dear heads of medical units, how do you fight this Soviet something with lysine? Prescribing like different stuff. Okay, with IVs. I'm from an imaginary battalion. I will not create some PR. So I had a conflict with medical unit at some point that I don't want the lysine. At night, I stole the box of it and I burned it. We have 3 heads of medical unit. So mine doesn't care basically. So how do you handle the issue with these medics? You can't send them for the pit and you can't like dismiss from the army. Okay, how to teach everyone, how to bring the idea, okay? With words. It's long and painful. It works, but it takes time. It's hard. It requires time. It's something that we had nalbuphine. It's the same with other drugs. But the majority of people can change their opinion, the majority. Just for each one, you need to have a proper approach. Okay, if a person is taking some substances, one approach. Those handling only papered or oral requests, another approach. Okay, if a pit works as an option, then it's a pit. It changes thanks to documents and decrees. We have people changing it here because it wasn't there.
Я думаю, тут дуже важлива має бути дискусія про накази, але
It must be a discussion on decrees, but we can't handle it because the medical force commanders left. Okay, can I give a comment? So I was an expert in the stroke group. I have a feeling that I'm at the same forum 7 years ago, the same thing, lysine. Everything we have for concussion now, it was for strokes. I prohibited to buy lysine, and they even complained to president for strokes. And I have a feeling that I have the feeling of the 7 years ago that I'm somewhere there. Almost no lysine there for strokes now. You can't even imagine how much of it we had 7 years ago. I'll tell something, I will sound like an anti-vaccinator. Okay, a company that produces lysine and albuphine, as long as they have this marketing, you will not get rid of that. Sorry. It's about money. Friends, just concluding, the panel was a very active discussion, and we'd like to have more, of course. I'd like to remind you that on the second day and the end of the conference of our Congress, we will have a resolution. And please join it. I hope that Ms. Ksenia will tell us how this can be done. I think we can have more of useful things brought from this discussion to tactical level. Let's say, speaking of concussion, we want to have more guidelines from our commanders. Okay, we want still to have decrees, Katarina, because some people need decrees, and we have to cancel those which are not functional. So we don't want to copy something that we have elsewhere because we may have a different. Well, everybody thinks of MACE, but nobody speaks positively of MACE. And please remember all the ideas and insights you got during the discussion. Bring these to resolution, right? Because we need to make history. We already have some. we will send. Okay, I think that not everybody will require this. We'll push all our today's insights there, and tomorrow when we finish, we'll monitor it and take the notes. Okay, thank you so much. This was a very fantastic discussion. Sasha, thank you as well. Now we have lunch, but I think food will wait for us. So first of all, we have flowers and nice food, and again, I tell you that we have wonderful 8th floor. You can just go there and see the landscape, the view, the Kyiv landscape. So today after 6 p.m., you will have an acoustic surprise, a specific one, made by a friend, veteran psychotherapist, and you can actually even participate in that. Trust me, you'll love it. So I announce you not to leave us at 6, but please join the event and enjoy your meal.